and turn on this presentation and turn it over to Mike.
All right, great. Thank you so much. Is there any place in particular you want me to sit? Or
no, you're good. There's fine if you want to come around here.
Okay. No, this is great. This is great. So thank you, Jonathan, for the great introduction, and thanks everybody for tuning in. And I really want to say a sincere and heartfelt thank you for just the opportunity to speak with this group and on this topic. I think it's something that's very important that we've been talking more and more about safety of opiates and how they impact our community and our safety. And I'm just happy to be here and to be a part of this. So when Jonathan came to me and said, hey, we're doing this program, it's called SPOTS, Safer Prescribing for Opioids After Trauma and Surgery, and we'd really like you to come and talk about how it affects the pre-hospital care and the pre-hospital setting. I thought, yeah, absolutely, I would love to do that. But EMS providers and out-of-hospital care providers don't really do any prescribing per se. But they do have to deal with quite a bit of the aftermath and the downstream effects of these prescription medications. And so I know that the previous sessions have really been mainly targeted towards the physicians and the PAs and nurse practitioners who are giving prescriptions to patients after they have a surgery. I would like to just take this as an opportunity to maybe tell them the rest of the story and how some of these impact people when they're out in the community in ways that you may or may not expect. So just by way of disclaimers, I do not have any financial disclosures to make for this group. I do have one kind of personal disclaimer that I should make, and that's that I worked the overnight shift last night, and I've had probably 3 of like the biggest Red Bulls I've ever seen. So there's a good chance that I'm going to talk a lot faster than normal, and I may develop a transient dysrhythmia, but I'm pretty sure I'll get myself out of it, no problem. And then Dr. Kohler already put this up there, but just as a quick reminder for credit for this session, you can text in the code at the number in the middle of the screen or email to Project Echo. So in terms of objectives and broad strokes for this presentation here, I really have 3 topics that I'd like to cover. The one is probably going to seem a little basic for about half of the audience, but I'm guessing that for the other half of the audience, this may be something that you're not quite as familiar with. So I'd like to just get into the abilities of out-of-hospital providers and what options they have when talking about responding to the opioid epidemic. I'd like to get into the alternative field treatments. This is something that is gaining a lot of traction in the pre-hospital community. It's actually something that's being backed up by the state. What options do we have for things other than narcotics to treat acute pain or chronic pain? I think that the changing attitudes of providers in the field is something that, there have been some unintended consequences from this, and we'll get into that a little bit. And then wrapping it up, just laying out what some of the community resources are that are out there, what we're looking at or what we're trying to do for surveillance and tracking of overdoses and opiate misuse and abuse. And then even some of the things that we're looking at to try and get out in front of this and try and stem the tide of the opioid overdose epidemic. One thing that comes up not infrequently is the little badge at the bottom of the screen here. I Narcaned your honor student is something that a lot of the out-of-hospital professionals like to wear as a badge of honor. And this kind of feeds into some of the changing attitudes that are out there, and just looking at the landscape. It's a little tongue-in-cheek because everybody who's in this field, I think, is a compassionate and a professional. That sometimes it does get to be a little bit of a drain when you feel like you're trying to hold back the tide and you're not winning. So if you'll entertain me, I know I caught probably 3 or 4 names out there that I recognize that I know are very well versed in out-of-hospital care. But I'm not so sure that everybody really knows this. And one of the things that I have noticed over the years is that the perception of the public at large is that when I pick up the telephone and I call 911, I'm going to get a paramedic showing up in the ambulance. And the truth of the matter is you may or you may not. And part of it depends on where you live in the state and what resources you have available in your community. There's really 4 main levels of out-of-hospital provider that you'll come across in the state of Wisconsin and really nationally. The entry level for out-of-hospital professional care is the first responder or the emergency medical responder. And this group is trained in really first aid techniques. They're great at basic hemorrhage control, splinting and immobilization. And when you look at sort of broad strokes, who falls into this category, many firefighters across the state are in the EMR first responder, and then some law enforcement agents out there are actually certified as first responders. The next level up is the EMT basic, and as you go deeper into the EMS levels of care, obviously it's an increasing commitment, not only in the amount of time that you spend in school, but it's also the amount of time that you spend on your continuing education and earning credit hours for that. And it's also an investment of your organization. So just like, you know, a pediatric trauma surgeon draws more of a salary than a lowly emergency physician like myself, we kind of move up the food chain from first responder to paramedic too.
I'm not sure that's true. But.
So the EMT basic, so they do everything that a first responder can do, plus they are allowed to assist patients with their prescribed medications. They're trained on how to use auto injectors and inhalers. When you look at who is certified at the EMT basic level, there are some fire departments across the state. There are many of the volunteer EMS services. The advanced EMT is the next step up. So the advanced EMT can do all the things that the basic EMT can do. Plus they're able to start IVs, they can start IV fluids, and there are some select medications that they can actually push IV. And this is where you start getting into many of the professional and career services that you see. And then finally, the paramedic, again, this is all of the out-of-hospital meds that are authorized by the state. And most of the time when you're getting into the paramedic level service, these are usually the full-time professional paid career people who are doing this all the time. When I put those levels, you know, volunteer, professional, most professional, again, you know, the saying in EMS is when you've seen one EMS service, you've seen one EMS service. There are many, many permutations of this, not only across the county, but across the state. But just kind of in broad strokes, this is generally how it shakes out. Under the previous DHS law, who does the regulation of the scope of practice for EMS, Narcan was in the advanced EMT scope of practice. So it wasn't until you got to that level of training and certification that you were able to give the antidote for opiates. And that's not a bad thing. You know, just like everything else, the state needs to have certain checks and balances to make sure that the right medications are not only getting to the right patients, but they're going through the right hands who have the right level of training. When you take one step back though, and you look at the system and how it's generally set up, the people who get to the emergency scenes first, the first responders, are generally law enforcement and firefighters. Because law enforcement, they have more nimble vehicles. There tend to be more of them out on the streets. They're able to respond much quicker. The fire trucks generally are stationed in strategic places where they can get there a little bit faster. And then the EMTs and paramedics are, you know, again, a little bit fewer between, and they're getting to the scene, you know, second and third in some of these calls. And again, you know, the level of service of your EMS provider that shows up is going to depend on your community and what you have available to you. So the reason why I spend time in this is because when you think about the system that we have in the state and who's going to be showing up to respond for your emergency, particularly when we're thinking about overdoses in the opiate setting, first person to show up is more likely than not going to be a police officer who may or may not be trained to the first responder level. Next will be a firefighter who's probably going to be to the first responder, maybe the EMT basic level. And then if your community is a small rural community, you may get an EMT basic service to transport. You may get an advanced EMT. If you're really, really lucky, you might get a paramedic. Now, the problem here is under previous rule by DHS, none of those first three groups could carry naloxone or Narcan. And that was, by and large, it was okay. Particularly here, you know, opiates, heroin, I don't want to say it was somewhat of an exotic problem, but it tended to be something that, you know, we thought of as being an urban, big city problem. It wasn't so much of a big deal. In the state of Wisconsin, the system seemed to function well. But as we're all now, I think, pretty painfully aware, in the late 2000s, early 2010s, we noticed a big uptick in the number of opiate overdoses that were happening out in the community. And this started at big swaths. You know, we saw things in Ohio, we saw things in Pennsylvania, we saw things down south where there were more and more people who were needing to be resuscitated after an opiate overdose. And so nationally, we saw providers who were trying to push the envelope to prevent those overdoses even before that wave had hit the state of Wisconsin. So they were starting to put out Narcan and naloxone and making it available for users of opiates and heroin and IV drugs. And then they were also trying to make it more available for first responders. So right about that same time, the state of Wisconsin, again, like very proactive and thinking ahead, said, hey, we should do a pilot program to see if we can push this safely down to a lower level of service. And so they started doing some pilot programs across the state with the EMT basic, making Narcan available to them so that they could effectively treat the overdose epidemics. And then the idea was they were going to prove that it was efficacious, it was safe. We would expand the scope of practice for the EMT basic and allow them to carry Narcan as well. Now that was great. And during the pilot phase, something kind of interesting happened. And that is two things really. So the state of Wisconsin and the legislators, I think in a very remarkably forward-thinking decision, decided to pass Acts 194 and Acts 200. And this was in late 2013, early 2014. And what these two acts did for the state was Act 194 didn't totally absolve people who called 911, but they were trying to lower the bar so that people would be more likely to call if there were an overdose. So what Act 194 does is it gives some protection to the person who picks up the phone and dials 911 or tries to get first aid to that person who's experiencing an overdose. The reason being, anecdotally, they had noted a number of cases across the state where people are together, they're using opiates. One of the two has an overdose. The other one recognizes, oh man, I need to get help for this person. But if I call, the police are going to show up first, which we've already established. I'm going to either go to jail or I'm going to be in a lot of trouble. I'm going to clean up all this paraphernalia first, hide it, then I'll call, and we're losing precious time. So the state stepped in and passed 194, which said, hey, if you call, it's going to be okay. You know, we're not going to come and prosecute you as heavily as we would have before. Please just make that call. The other thing that they passed was Act 200, and this is very, very wordy, and it's probably about as exciting to read line by line as you expect it to be. But the gist of it is Act 200 allowed the Narcan to be open to everybody all the way down to the first responder level, as long as they had appropriate medical oversight and a good relationship with the medical director. A lot of this came out of the fact that, in some of the bigger metropolitan areas, we were allowing Narcan prescriptions to be written to users, it doesn't make sense that an average person who's using heroin could be given Narcan to use on themselves or their friends, where in the state we're keeping it up to the EMT basic and higher. So bringing it down to that first responder level meant that not only were the paramedics, EMT basics, and firefighters going to have access to it, but it also got law enforcement involved. And a really unique thing came out of this was that the relationship between EMS and law enforcement got a little bit stronger. So they started working together a little bit more. A lot of the law enforcement agencies across the state paired up with whoever their local EMS provider was so that they could share training, they could work together, and they could really have an impact on saving lives. And then again, just how this translated into state statute. Again, it's really the same wording that it went down to firefighters, law enforcement agencies, and law enforcement officers to dispense Narcan to try and fight back against this overdose epidemic. Just a little bit easier way of reading it. You know, again, 194 grants immunity from certain criminal prosecutions because of possessing or being related to a substance or controlled substance analog. And then Act 200 really does make the prescription possession and dispensing of the opioid antagonists easier for first responders. So looking at the DHS statutes, so the DHS is really what regulates EMS care throughout the state. They're the ones who say, this is what you can do, this is what you should do, this is what you cannot do. When you pull up some of the medications, the assisted patient medications, you can see naloxone that's highlighted in red is an optional carry for the EMR and the first responder. For every other level of certification, it's a required medication that they have to have available to them in their arsenal. I think making it optional to the EMR was a very smart and a very strategic move because there are a lot of, well, I wouldn't say a lot, there are law enforcement agencies across the state who have very tight budgets, and I would hate to be the person in charge who had to make the decision, am I going to invest my money in Narcan or am I going to invest it in Kevlar and bullets? So, you know, both of them have a weight to them, and not all of the EMR services have elected to carry it, but I think more often than not, they have gotten on board with this because they've seen that it does make a difference. So switching gears a little bit here, DHS, and this is somewhat newer, they have come out and said, yes, we acknowledge that there's a problem with opioids in the community, and they're starting to push a little more heavily on other non-narcotic options for treatment of pain. So I just pulled some snippets from the state website here. You can see Tylenol is one that is out there, and they are actually going to make it a required carry by 2020 for the advanced EMT and the intermediate, which is another level between advanced EMT and paramedic. And then ibuprofen and Advil is another one that is going to be a required carry. And it's required for the paramedics and the critical care paramedic. That's what CCP means on the right side of the screen. They have to have at least one non-steroidal anti-inflammatory that they have in their arsenal, whether it's ibuprofen or Toradol is the other big one. Ketamine is the perennial all-star here. Ketamine is one that everybody seems to be very heavily in favor of. I'm going to come back to that point a little bit later on here. Also interesting in the scope, Nubane is a narcotic pain medication that doesn't have a lot of the euphoric effects. This is another option that's available for paramedics and critical care paramedics. It's not one that I have seen picked up very frequently. And then naltrexone or Vivitrol is another medication that's available or an option for paramedic and critical care paramedic if you wanted to start somebody on a long-acting opioid antagonist. Again, this is starting to hedge into that. I mean, I'm engaging in a relationship with this person in their long-term sobriety, which is both good and bad, and it's kind of a mixed bag. I think that looking at the Vivitrol and the naltrexone treatments, not so much today, but in the near future, I'm curious to see if maybe some of the community paramedics and community EMS services don't start carrying that. And then nitrous oxide is another one that I think it probably would be surprising to a lot of people to learn. Nitrous oxide is something that we use very frequently in the emergency department for pediatric sedations. I know they use it in burn clinic all the time. But this is a medication that's available down to the level of the advanced EMT. So maybe a little bit surprising on that one. And I'm going to come back to that and ketamine in a couple minutes here. So the non-narcotic analgesics in field use, I think that these are both a pro and a con in some ways, particularly the Tylenol, the ibuprofen, and the Toradol options. I do think that patient perceptions of pain management are going to come into play with this. So just if you were to imagine you or your loved one were in a bad car accident, you're injured, you've got some bumps and bruises, you're going to get transported to the hospital, and the EMT or the paramedic were to offer you Tylenol. I think that the perception of medications just because they're over the counter aren't as effective, even though that's really not the case. It can lead to somewhat of a dissatisfier with them in some ways. There is some medical director angst regarding these medications too, because the very logical question that comes up is, if I'm medical director for an EMS service, we run on a patient who's got a pain-related complaint, I dispense something like ibuprofen or Toradol, and they say, you know, I feel better, I'm not coming in. Where are we in that management, and how do we manage that relationship? One of the complications then is for a lot of the services in the state, if I go on a call, I dispense a medication and I don't transport, one, they don't end up getting reimbursed for that call. And then two, you know, there's always a lot of concern for the non-transport patients that there was something significant enough for them to dial 911, for them to be left in the field can sometimes be occasionally dangerous. The other one that is probably the big bugaboo is Toradol, which is a very strong anti-inflammatory. But I can tell you from personal experience that some of the surgeons, and particularly the trauma surgeons, do get a little bit upset if a patient has been given 30 milligrams of Toradol for pain control, and then they have to cut on them for some reason, because it does prolong bleeding time and it can make things a little more complicated. So that's something where at the medical director level, you know, we have to try and balance what's the right thing to do for that person. Nitrous oxide. So nitrous is a really interesting medication, and it's sort of an interesting drug for use in the field. So when we use it here in the ED, we've got a big set of regulations that happen with it. So you have to have the key, you have to be able to unlock it, you have to be able to access it, there's a scavenger system. When it's given in the field, it ends up being the patient has to control their own medications. So they have to be able to follow commands to hold the mask to their face, to inhale until they get appropriate anesthetic. And then that hand kind of falls away with the mask as they get more calm and relaxed. They go back to breathing room air. If they wake up and develop pain, they can self-regulate again. In that regard, I think it works beautifully. The area where it gets a little bit sticky and the area where it's complicated in action is OSHA will tell you that if you have a gas flowing in the back of an ambulance that causes general anesthesia, how do you guarantee that there's a scavenger system in place that you don't influence or intoxicate the other members of the cabin, right? So super tricky. There are some services here in Dane County that are using nitrous on occasion. Their experience with it has been actually very good. The other thing that comes up with nitrous, obviously, is the potential for abuse. And unlike having multiple vials of fentanyl or morphine where you can quantify how much is in there, having a compressed gas like this is much more difficult. So if you pick up that canister of nitrous, does it have 5 pounds or does it have 4.8 pounds? How much is in here? How much was in here?
tricky in that regard.
Ketamine. So I really like ketamine. I think that it is a wonderful medication and it has a good time and place. The one thing that gets a little bit tricky around ketamine is that there are several groups of providers, including some of the doctors that I work with in the emergency department here, who firmly believe that ketamine should be added to the water supply and gently sprinkled about the community on a daily basis. It's a little tongue-in-cheek, but they do like to use it for just about everything pain-related. The point that I usually make with the paramedics and the EMTs is that it is still a medication, it is still a drug. It does have side effects and consequences, and if you aren't paying attention to what you do or how you're using it, you can get into trouble. That being said, we have greatly expanded our protocols for ketamine here in Dane County. We use it quite liberally for behavioral emergencies, but then we also use it as an analgesic adjunct in low doses. So a lot of the literature that's out there, particularly in the trauma surgery literature and EMS literature, would say giving somebody a dose of ketamine significantly reduces the amount of opiates that they need to achieve good pain control, and it's all at the subdissociative dose. Okay. So provider attitudes have been changing quite a bit, and this is all in response to the drumbeat that's been coming out. We keep hearing opiates are an increasing problem. They're not just the young person's problem who lives in the inner city. This is not a New York and a Los Angeles problem anymore. This is a suburb problem. This is a rural problem. This is an everybody problem. This is a young person. This is an old person. Everybody is at risk for developing dependence and abuse. Everybody's at risk of overdosing. And it's just kind of gotten beaten into the heads of the providers out there. And they hear it and they get it. They absolutely get it. But where they get kind of stuck in a hard spot is there are a lot of patients who have chronic conditions that cause pain. There are the fibromyalgia patients, there's the rheumatoid arthritis patients, there are the people who have had bad traumatic injuries in the past who need some of their prescription medications. And so the frontline EMS providers, as opposed to those of us who practice in the hospital, I had the option of picking up someone's electronic chart, flipping through it and saying, oh, hey, this person's been seen multiple times for pain-related complaints. They've got a history of overdose. They've got a history of abuse or misuse. I'm really going to be very judicious with how I manage them. Unfortunately, the electronic patient care records that are out there and available for most of the EMTs across the country don't have that as an option. They put in the information that they're given. They're somewhat acting on good faith and flying blind. And so a lot of times they find themselves caught between these two very divergent and conflicting initiatives. They want to help people. They want to treat their pain. They also don't want to feed into somebody's potential addiction or make them sicker. The other one that has come up several times too is, and this is a really sticky one, so just because somebody has a history of opioid abuse or dependence doesn't mean that they can't still have a very painful injury. So that fall from a ladder with a broken tib fib or the car crash and the deep lacerations, those are all painful things. And more I've heard stories of EMTs and paramedics who pick up patients who say, dang, son, that looks like it hurts a lot. I'd really like to give you some pain medication to help relieve your suffering. And the people say, no, I've had a problem with opiates. Please don't give it to me. So we've got it kind of coming from three different fronts of, I don't know who's gaming the system. I don't know who's a chronic player who needs this. I don't know who's got a history. And so unfortunately, they wind up kind of stuck in the middle. When you look at the overdose rates across the country and how much they have changed. It's a little bit small for the graph on the left, but I think I'll drive home the point with a couple that follow up here. The light blue dot on the left is the overdose deaths per 100,000 in 2010. And then the dark blue to the right is the overdose deaths in 2016. And you can see Wisconsin right there. We've got a pretty narrow change as compared to some of the states up at the top. And our numbers overall are relatively low. We're not doing quite as well as North Dakota, but we're doing a heck of a lot better than West Virginia. That being said, when you look at the trends across time, and this is all data from the CDC, looking at the number of overdoses that happen per 100,000, and these are age-adjusted rates for overdose death in 2014, 2015, 2016, and 2017. Even though overall the state of Wisconsin is doing pretty well, we are continuing to climb steadily up that ladder. So we need to do better, and that's what everybody really wants at the end of all this, is to figure out how we do better and how we help more people. Bringing it back to the first couple points that I made, the first responders who are on scene, the ones who are having the first touches with these patients, tend to be law enforcement. And this was a really interesting graph that I pulled again from the CDC. They are really the ones who are the wealth of knowledge on this topic. This is the number of encounters with law enforcement between 2010 and 2015 that tested positive for fentanyl. So fentanyl, just as a reminder, is about 100 times more potent than heroin. It gets added to the opiate supply for some of the IV drug users, and obviously increases the number of deaths. There has been a dramatic uptick in the number of synthetic opioids that law enforcement have come across in the last 3 years, the last 3 years of data that we have. As a result of this, there's a lot of fear and maybe some misinformation and some paranoia that comes out of this too. So I think the popular media has highlighted, and I don't think it was maliciously done, but they have greatly popularized a number of stories of law enforcement agents who come across a white powdery substance that then suddenly start developing symptoms. So this is just one story from last June of a couple police officers who started to feel symptomatic, and they had to administer Narcan to themselves. The literature will tell you that the rate of absorption through the skin for even a strong synthetic like carfentanil is very low. They talk about the transdermal patches of fentanyl, but those have to be chemically modified and held on your skin for about 8 to 10 hours before they really start to penetrate. These are all short exposures. That being said, their fear and their concern of having an overdose, particularly with coming into contact with it more frequently, is very, very high. They're very alert of this, and they don't want to become a victim themselves. On the flip side of that coin, they've also had so many contacts that a person is unresponsive because of an opiate that they kind of click their brain into a different default setting where if somebody is not alert, unresponsive, this must be an opiate overdose. And so there have been a number of stories anecdotally and even a couple locally where the message is, yep, we just get all the officers to line up with their Narcan and we each come by and give them intranasal Narcan until they start breathing again. Well, it works for a lot of those cases, but every once in a while, you'll have a person who's unresponsive because of a medical emergency. And this is another one from just this last November of a woman who was having a bad asthma attack that they kept throwing Narcan at her when what she really needed was albuterol unassisted ventilations. So again, you know, we talk about the EMS providers getting hit from three angles. Who's trying to game the system? Who needs me? Police officers are in a very similar situation. Plus, they're all worried about their own safety. And then just another graph to kind of drive home that point. You can see the overdose rates for the majority of substances out there have been slowly increasing over the last probably 18, 19 years, but there's been a huge spike in the last 2-3 years with the synthetic narcotics. What does this do to the provider attitudes and their feelings towards opiates and overdoses and just the general population? So law enforcement and the first responders, they have a lot of fear, and they're not just afraid of the patient encounters and the patients having a bad outcome. They're afraid of them and their partners and their canines getting exposed to these highly potent chemicals. They're worried about taking something home to their family on their uniform that could potentially make their family sick. They're worried about these fentanyl analogs and these things coming in from overseas that they don't know how to combat and how to fight. And they are all very worried about what's the appropriate level of PPE, because there wasn't a good amount of guidance for a long time. The other things that factor into this too are the Narcan and who can administer it. Obviously, as Narcan has become increasingly popular and more available, it affects the market price of it. Are you still going to be able to get access to this medication when you need it all the time? It's a free market, so it drives the price up and it makes it difficult to administer. The route of administration has been the one area where I think I've seen the biggest change in perception for both EMS and law enforcement. So if you rewind the clock 10, 12 years, EMS, advanced EMTs and paramedics used to love starting an IV, giving somebody 2 milligrams of Narcan and watching them wake up. It was fine when you were doing that once a year, once every couple years. But with the increasing number of overdoses that they're going on and with the side effects of IV Narcan, they've actually changed quite a bit from the IV route to the intranasal route. The reason being, when you slam somebody with IV Narcan or IO Narcan, they immediately go into withdrawal. They come out, they are angry, they are combative, they are trying to run away. They're also at an increased risk of non-cardiogenic pulmonary edema as a side effect from this too. So then these people, not only do they get angry and try and run away, but then they develop respiratory failure, respiratory distress, and they need to have advanced interventions made. So a lot of them have switched, and preferentially so, to the intranasal Narcan. The thing that they have noticed is that it's a much smoother wake up. The first thing that comes back is the spontaneous respirations, which is really the only thing that we care about in EMS. I don't need to talk to you about your opiate overdose. I get it. I understand what happened. I need you to breathe, and then we need to just observe you for the next couple hours to make sure that you're safe, and then we can get you hooked up with the recovery coaches or into detox or whatever happens next from here. So again, we're going away from I need you to wake up right now. I'm going to use this as a little bit of punishment and that you shouldn't do that, and more of I just want you to breathe so that we can all have a nice smooth wake up from this and everybody's happy. What does this all translate to? Law enforcement, again, I think that there's a lot of fear and apprehension. On the EMS side, I have seen a lot of compassion fatigue. So I hear stories about multiple runs going to scenes where there are parents who have both overdosed on narcotics, and there's a child in the home, or there's even a child in the car. The recidivism rate is crazy high. There are stories of people who are getting Narcan 2, sometimes 3 times in a single day because they've overdosed. And what it leads to is just this feeling of helplessness. Of I can't win. This thing has such a strong grip on my patient that I can't ever break them out of the cycle. The overdose stereotypes have been broken. It used to be, it's a young person's problem, it's a club problem, it's a big city problem. Now it really is everybody. And not only does it affect everybody across the country pretty equally, it's also more difficult to pick up on too, because and one of the slides that got dropped out of here was the overdoses that are actually multiple medications working together. So if I combine an opiate and a benzo, I'm much more likely to overdose. But when I show up as a first responder or a medical provider you don't have those pinpoint pupils that you normally do. You might not have that super shallow respiratory rate. It just might be an overdose NOS. And they're picking up on the fact that these people are waking up with a little bit of Narcan. They're coming around. As a just quick aside, I have been talking about this for a long time, right? Like, yeah, you can look at the pupils, but don't trust it. And for the longest time, it's crazy old man Lohmeier doesn't know what he's talking about. And then you get a couple anecdotal cases, and like, oh, he was right. Like, I gave this guy Narcan, his pupils were huge, and he woke up, so it must be opiates. There are a lot of cases now of a reluctance to administer narcotics to people. They have I use the word punishment mentality here, but it's probably not the right term. It's just these are the negative consequences for you making bad choices in your past. I'm not going to relieve your pain. And really what it comes down to is just that cynicism. I'm not sure who to trust in all this, so I'm just going to hold back on everything. And it ends up being not great patient care, unfortunately. And then the other one too, transport after resuscitation. So here in Dane County and most of the protocols across the country, if someone is given Narcan to wake up, the protocol is that person should be transported to an emergency department where they can be observed for 3 hours. This is another one where I've been vindicated because the literature for the longest time was, we did all of this autopsy review and we did all, reviewed all the obituaries, and nobody who got Narcan and ran away ever turned up dead. But we've been seeing it more. And I think it's because of the increasing potency of the narcotics that we're seeing here, the increasing frequency, the things like the non-cardiogenic pulmonary edema that, again, everyone was like, old man Lohmeier's full of it. You see a couple cases of that, you see it happen. It's not that the incidence of it is more prevalent, but the frequency is more prevalent because you're getting more overdoses. So you actually see those cases. And so a lot of the lights are coming on like, oh, hey, maybe these protocols aren't so crazy. And then the community responses, I'll get into that here next. So there have been a lot of community groups that have really come together and focused on opiates and how we can try and make a positive impact, how we can bend this curve in a positive way. One of the ones that has been acting locally is a group called Safe Communities, and they have a really broad mission, which is injury prevention, drug poisoning, traffic accidents, falls prevention. But they've been very, very supportive and very early adopters of trying to change prescriber mentality towards opiates and narcotics. And so they were one of the first ones to go to the dentists and say, hey, you guys probably should review how much Vicodin you give after a wisdom tooth extraction. They were ones to really advocate to the pharmacies to say, hey, you guys need to talk to each other more. You need to look at the prescription drug registry and find out who's using these and who's misusing them. They also were big advocates, and they were behind the recovery coaches. So recovery coaches is something that is very big locally, and we're trying to expand it out throughout the state. But basically, the recovery coaches are certified coaches who have gone through a course to be a recovery coach, who are previous addicts who are in recovery. And it initially started off with patients who had an opiate overdose who we brought into the emergency department. We would link up the person who had overdosed with a recovery coach so that they could get to them at that vulnerable time in their life and hopefully get them into a treatment program so that they could get better. It has since been expanded, and now they don't have to have an overdose to get hooked up with a recovery coach. Anybody who's identified in the emergency department or even in the field by EMS can get referred to a recovery coach, so that it's kind of like having a sober coach or a life coach who helps you hopefully make some better decisions. And then there have been a number of same-day access treatment centers. So I think the thing that's probably the most frustrating for me as an ED provider is to see somebody who comes in after an overdose. They say, I need to get clean. I need to stop doing this. And I say, great, here's a referral to a program that might be able to get you in 3 weeks. Well, that window is closed by that point. Like, you have an opportunity to intervene, and you need to take advantage of it. So trying to find more same-day access treatment centers are going to be big. what's the future hold? So I think that there's a lot of things on the table, and a lot of them are very interesting. So we in Dane County have been looking at two programs. One's called First Watch, and another one is called OD Map. The First Watch program is basically a program that takes the dispatch data from the dispatch center. It takes the electronic patient care reports. It takes information from multiple sources and pulls it in together to almost a real-time report out on where the overdoses are and what's going on. OD Map is another newer one out of Baltimore that allows EMS providers and first responders to actually program in when they go on an overdose. And it creates almost like dropping a pin where you leave your car. It leaves a pin where you went and treated an overdose. And it helps law enforcement and other officials kind of dial in on where the hot spots are so that they can hopefully intervene and prevent further overdoses. The community EMS and community paramedic, this is a new thing that just got opened up by the state of Wisconsin. So Act 254, I think it is, basically opened the door to say that the community EMT and the community paramedic is a certification that we can have in the state. I think that what will happen is these will be outreach people who will help touch some of these people who are struggling with opiate use and misuse and try and get them linked up into recovery programs too. And then growing partnerships between emergency departments and recovery coaches, treatment facilities are all things that have been expanding over the last few years so that we can build that network so that nobody falls through the gaps. That was a lot. I talked fast and I still feel like I left almost no time for questions.
That was awesome.
I'm sorry.
No, it's fantastic. We'll stop the share here. And feel free to use your, either unmute yourself or use the chat function for any questions.
While people are unmuting themselves or talking, one of the things that I practiced in Philadelphia before I came back to Wisconsin, we had a huge opioid problem and still do. I think we just got the record that nobody wants. The DEA's largest bust ever was in Philadelphia a couple of weeks ago with billions of dollars worth of drugs on a cargo ship. But it was so bad that they have standing orders now, so community members can go to Walgreens and say, I want Narcan, and you don't need a prescription anymore. And so one of the things we saw was drug dealers were actually giving out heroin with Narcan to say, my stuff is so good, you should carry this in case. And that was a marketing tool, and actually because of the mindset of addicts, that was actually a successful marketing tool. And so we saw people seeking out the drugs other people had overdosed on. And one of the phenomenons that you had kind of alluded to was they clean up the scene before you guys get there.
Right.
We actually saw them stealing bag masks from the hospital once they saw that's how we saved them. And so we had to start keeping track of bag masks because they were walking out. But one of the things that we always ask too is, did you give any medications before we got here? Because they wouldn't always say, by the way, they got Narcan. And so they might be lucid or at least breathing. And then as soon as that narcotic stays in their system longer than that Narcan, which is why we observe them, then they pass back out, and we see the kind of the recidivism instantaneously, not knowing that they already got Narcan. So,
right,
another thing to keep in mind.
I do think it's just like so important to think about the pre-hospital situation, because you guys are like, you're the first stop and the last stop in this opioid issue, right? You're the one who picks up the patient with the tib-fib fracture who then goes on to develop the opioid dependence, and you're the ones who see that patient, 3 years later when they have their fentanyl overdose and are managing that. I mean, it's like this is happening in the community, and so it's the people in the pre-hospital setting who are seeing the community.
Yep. And it's, part of this was when we first talked about coming and doing this presentation, I knew that it was going to be a big audience. And so I'm sure that there are some people who maybe hadn't even considered how, I gave a prescription for 20 Vicodin. It's no big deal. But when you kind of look at the broader landscape, your 20 Vicodin might be leading to somebody's overdose, and EMS gets called to that. You don't even hear about it necessarily.
Right.
If they
it's
get
not the patient you prescribed it to who's necessarily
right. That too.
It,
The diversion of meds is a huge problem that I didn't even get into with this.
Other questions or comments in our last minutes here?
That means either I bored them to sleep or.
Sometimes you got to give a minute for
Yeah.
the
Oh, I
unmute
know.
to happen or people to type.
Yeah. Thank you.
Thank you. All right. Well, thank you everyone for coming.
Thanks,
Thank you again, Mike Lohmeier. This is just a fantastic and comprehensive description of a huge problem, and I know I learned a ton about the nature of the pre-hospital situation that I didn't know. I have a million questions that I'll have to ask you offline.
Sure. Yeah, because Ben's got to go now.
Ben is now going to be presenting on our Project Echo line, so we'll drop off this call, and then we will be taking up critical incident stress debriefings for the pre-hospital and emergency department community on our Project Echo. If you are interested in joining that, you don't already have a email about it, feel free to join us. The meeting ID for that, it's the same Zoom program, but the meeting ID is 608-263-7697. That's 608-263-7697, and we will see you there in like 2 minutes. Thanks so much.
Thanks, everybody. It is warm in here.